Hello, my name is Tyrell Steins, critical care paramedic and field educator for Lifestar Emergency Medical Services. Today we're going to talk about PICC lines and central lines. Obviously, these are some nightmare scenarios. I am going to want a bigger ambulance and, a couple extra people in the back for me. But looking at PICC lines, the state of Wisconsin says that as a paramedic, you don't need any additional training during a code situation. However, to access, you do need additional training with your medical director's approval. Lifestar has approval for our paramedics to access and maintain PICC lines and central lines. And critical care paramedic, it is required by the state. So we are approved to use them, and we just need to make sure that we maintain our training, which is what this video is about. Here is a lovely IV pump Christmas tree that somebody put together. Somebody had a little time in their hands on the ICU probably. PICC lines are peripheral inserted central catheter, and they come in very many different shapes and sizes, different locations. What a PICC line is it's not an IV catheter, and you can't put them in the field. You need special tools to put them in. It's much different where the catheter ends. The biggest being it's a central line because the distal end of the catheter terminates right above the right atrium. And the removal procedure is completely different. PICC line removal is actually a full-blown procedure. You have to have the patient sitting in a certain manner. You have them take a deep breath and hold it while you actually take it out. It's completely different than the removal of an IV. Also, the catheter tip. There are many different types of catheter tips, different endings. Some that end all together and have holes perforated along the distal end, but actually come to a close. Some are self-occluding, and so they collapse at the end unless they're put under pressure. So PICC line is definitely not an IV. They come in different numbers, colors, shapes, sizes. There are a ton of different ones out there. There's the HemoSplit, catheter, Mahooker, Power Hickman, tunneled, non-tunneled, Groshung, and the colors don't mean anything individually. They are specific to that device, and so it'd been nice if they were all on the same page and all the companies agreed that this color for that. That is not the case with PICC lines. Although red is the most commonly associated with blood draw lumen, and typically it is the fastest lumen. All bets off, colors don't necessarily mean anything as they are very specific to each individual device. The numbers, we've all seen the 3 ml, 5 ml, 3.1 ml. What's that about? Well, actually it is associated with the milliliters per second that you can infuse, and there are specific pressures for each one of them and maximum pressures for each different PICC line or central line. The only case that I'd actually foresee us worrying about this would be if you accessed a PICC line and had a pressure infuser rag on it, which would be, I can't foresee anybody actually ever doing that, but you wouldn't want to do that because you don't know what specific pressure you're putting on that lumen, and there are maximums. So PICC line is kind of like a really long IV catheter, but it is a central line because you terminate right above the right atrium, and so it has to be treated as a central catheter. In some cases, there are different types of PICC lines. Some of them are referred to power PICCs, where they're capable of measuring central venous pressures, and so you have to know what the patient has and what it's capable of, what type of PICC line. Tunneled versus non-tunneled catheters. Tunneled catheters are kept in place longer than non-tunneled catheters. Non-tunneled catheters are fixed in place at the site of insertion, with the catheter and attachments protruding directly. Commonly used non-tunneled catheters include like the Quinton catheter. Tunneled catheters are passed underneath the skin from the insertion site to a separate exit site. And the catheter and its attachments emerge from underneath the skin. The exit site is typically located on the chest, making access to the ports less visible. The patient can hide them better versus catheters that protrude from the neck or the arm. Passing the catheter under the skin actually helps to prevent infection and provides stability to it. Commonly tunneled catheters include the Hickman catheters and the Grosham catheters. Dialysis catheters. We do not use dialysis catheters. There is always an exception in medicine, it seems. Why does there always have to be an exception? The Bard trialysis catheter has a power injectable third lumen, and only this lumen can be used for contrast administration and other things. However, it's best just to not mess with dialysis catheters, the exception being if the facility already has something running on it and then continuing it, that would be okay. But we don't mess with dialysis catheters, or rather dialysis PICC lines, and we never ever mess with dialysis fistulas ever. Central ports, they're not a PICC line, they are a central venous catheter. We do not have the ability to access them. Some paramedic and critical care paramedic services use them. They require a different type of IV needle. They are called the Huber tip needle. It is a needle that is cranked out at a 90-degree angle. Typically, they're about a 1-inch long and typically a 19 or 20 gauge needle. We don't carry them. They are quite expensive, but we've all seen the central ports on patients. The third picture, and you can see the extreme emphasis on the 3 prongs that you're supposed to palpate in order to feel before starting the line. We do not access them because we do not have the equipment and we're not trained to do so. It is relatively easy, but it's not something that we're authorized to do. Forget what it is. It's like $60 a needle or something ridiculous. We do not carry those, do not access central ports. You can see all the different shapes, varieties, sizes. You can see there's actually a double port down there where you actually get 6 bumps on your chest. The central ports are actually, you can leave these in almost indefinitely. You know, this is a surgical procedure. They're placed and they are meant for patients who are going to get long-term years of probable venous medication administration. Your cancer patients versus just, oh, you need to be on IV antibiotics for 2 weeks, we're going to put in a PICC line. The 3 sites for a PICC line, most common, femoral, jugular, and the cephalic. Femoral is falling out of favor due to its location, the ease of potentially walking, and the biggest being infection. Your crotch is just a breeding ground for germs, and so it's kept clean less. It's just not as sanitary as, say, a jugular or a cephalic vein would be. Most commonly placed in the non-dominant arm. You can shower with a PICC line, you can bathe. Just got to keep it covered up, taped up. You always want to make sure it's free from infection. Placement, like I said, this has to be placed inside a clinic or hospital under fluoroscopy or ultrasound. This is not something that can be done in the field. Generally, it only takes up to about an hour to place them. And so it's something that can be done relatively quickly. The dangers of PICC lines, obviously infection is the biggest concern. You have a direct straight line right to your heart, and you got to be super careful. Cannot stress this enough. Pretty sure nobody wants to put germs into a patient and give them sepsis. Sepsis kills people. It's very dangerous. Air embolism is another big concern. We've all gotten air into peripheral IVs. Not a good practice, but significantly rare complications versus air into a PICC line or central venous line. That is a completely different story. Venous air embolism can cause severe morbidity and mortality issues. Generally, small amounts of air are just broken up in the capillary bed and absorbed from the circulation without causing symptoms. Classically, it was estimated that 5 milliliters per kilogram of air displacement into the intravenous space was required for significant injury to occur. Now we know that that's actually a lower number. Complications with the arterial side of things takes very, very little. And a unprimed IV infusion tubing is about 20 mLs, depending on which version you're using. Injections of 2 or 3 milliliters of air into the cerebral circulation can be fatal. As little as a half a ml into the left anterior descending coronary artery have been shown to cause VFib. Half an ml into the pulmonary vein can cause sudden cardiac arrest. The closer the vein of entrapment is to the right heart, the smaller the lethal volume is. And where do PICC lines terminate at? Right above the right atrium. So we really got to do a good job. You cannot be putting air emboli into patients. You need to be very cautious and make sure to get out all of the air. It's not all doom and gloom. It's estimated that 50% of orthopedic surgeries produce air embolisms. But what's the difference between a blood clot in your leg, stuck in your leg, versus stuck in your heart, versus stuck in your brain? DVT versus MI versus stroke. Timing and placement. Where will that air get stuck? Where is it going to lodge? Much less the density of air, so it's going to rot. If you were to notice that an air bubble went in, you would want to put them in left lateral slight Trendelenburg position, because that way you could trap that air bubble. Just watch your practice. Be cautious, be careful, go slowly so that you don't mess up. And always examine the PICC line site. If it looks infected, don't use it, because it's full of infection. You're just going to push that out to the entire body. So setting up and getting ready. You have a patient, let's say nausea, vomiting, diarrhea, they're dehydrated, they're skin tenting. You see a PICC line, you're like, all right, I'm going to use that PICC line. Pull out a fresh, clean chucks. Prepare. In the OR, they prepare. They lay everything out, so that way everything is sterile as possible. Set everything that you are going to need out onto the clean chucks and get everything ready. That way you won't have to be touching more than you need to. Also, set up your IV line. If you're going to start an IV line and give fluids to this patient, one thing to consider is the air in the ports. I set up my line, and good for me, but I didn't clear out the air out of all of the little ports along the tubing. When you go to push your medication, you can see that little air bubble be kicked into the line, and where is it going? Right to the right atrium. Not a good place, not what we want to do. And so when you set up your IV line, draw out the air out of all the ports. That That way you won't have any problems when you go to administer medication. And so after we set up and get ready and lay everything out on our chucks, we are going to double disinfect. We are going to take our first alcohol prep, we're going to vigorously scrub the port, and we're going to count to 15 Mississippi scrubbing. Then we're going to put down that first alcohol prep, we're going to take a second alcohol prep, we're going to scrub it for 15 Mississippi again. And then we're going to let it dry. And don't blow on it. Dear God, please don't blow on it to make it dry. Don't know if you know, but there's a lot of germs in your mouth, and then you're blowing germs onto the freshly cleaned port. So double disinfect it and then let it dry, and then you can hook up your syringe. We always use 10 ml syringes. That has to do with pressure. If you use a 3 ml syringe, you can force too much pressure and collapse the line. Classically, 10 ml syringes are what we grab to draw off the blood and what we also administer medication with. We have our 10 ml syringe hooked up to the port. We're ready to draw off that 5 milliliters of blood, and it sounds silly, but unclamp the lock. Unlock the clamp. And PICC lines, you should always clamp the line, no matter if you're not using it, whether it be a PICC line or a regular IV line. It's good practice to always have it clamped shut when you're not directly using it. We've all started an IV, put on an extension, taped it down, gone to the hospital, and now it's all full of blood. Well, why? Well, pressures. What type of blood pressure is on the other end of that lumen, and is it going to push back up into the tubing where it can sit there and then form a clot? PICC lines specifically always need to be clamped off when they're not being used, because you're sitting right above the right atrium, and it depends also on what type of PICC line is placed. So always clamp it off. Disinfect it, get your 10 ml syringe attached, unclamp it, and then we're going to remove 5 cc's of blood. You're going to remove 5 cc's of blood, and that's done because many PICC lines are loaded with 5 cc's of heparin to prevent clotting while not in use. You don't want to push that 5 cc's into the patient. You want to draw it off, and that way you're also pulling back if there was a clot formed at the tip of the lumen. You'd suck it in and suck it out into the syringe. If you meet resistance, double check the PICC line for kinks and make sure that it is unclamped, and then attempt again. If you can't draw off your 5 mLs of blood, then we can't use it. In that case, we just have to clamp it off and leave it and start an IV or start an IO. Always make sure to tell whatever staff you are handing off the patient to that you drew off 5 mLs of blood, so that when it comes time they can reheparinize this. And so always make sure that it's known that you drew off the 5 mLs of blood. Then after removing the heparinized blood, attach your flush, make sure that you have adequate flow. Once again, always be very careful of air emboli. Now you can attach your medication and administer the med, or attach the IV line to give them a fluid bolus. So yeah, like I said, always remember to clamp it shut. We never leave central lines or PICC lines open. You're always going to clamp them off. And you have to be so careful about air emboli, because that lumen is sitting right above the right atrium. It's very dangerous. It's not just an IV. Additional notes, it is considered a central line, a central access. It's not an IV. An IV has to be replaced every 24 to 96 hours, whereas PICC lines can stay in up to a year. depending on the PICC line, can be longer, and if they insert a port, it can be basically indefinitely. Always make sure that the line is clear of heparin. That's why you're drying off those 5 mLs. So we double disinfect, and then we draw off, and then we can administer. Never take a blood pressure over the PICC line insertion site. Not a good practice. Another reason why PICC lines are beneficial is depending on the pH of the drug, it might be too much for peripheral administration. And so pHs of less than 5 or greater than 9 or osmolality greater than 600 should be avoided if possible and should be put through a central line. Here is a ginormous list, and you can see there's a couple of things that we take regularly or that we give regularly through peripheral IVs. The pH of morphine. I don't remember the last time that a physician started a central line to administer morphine. However, truth of the fact is morphine has a pH 2.5 to 6. Most come in at 4, and it's an irritant. TPN is another one on the list, and has a pH of 5.3 to 6.3 and an osmolality of greater than 600. And don't remember the last time that was a central line. And so you have to be very mindful on amiodarone. I've pushed amiodarone in the field on stable VTAC. You need to know that your IV is patent and flows well. These are things that these medications are definitely preferred that we push them through a central line, not that they can't be. Think about how many times you've taken potassium chloride and the patient complains about burning. That's because it's not very healthy for your veins. Be mindful of your IV site. When was the last time interfacility that you checked to make sure that the IV was patent? That you ask the patient, is there any itchiness, any swelling, any burning, double checking and make sure that it's patent. When was the last time interfacility that you did that? How many interfacilities has it been since you asked about somebody's IV? Here we have a case of a 61-year-old male was admitted for a NSTEMI. Day 3, went pulseless, VFib, defibrillated, administered 300 milligrams of amiodarone, and then they prescribed him 900 milligrams amiodarone over the next 23 hours through a peripheral IV. 24 hours after that, the patient developed a dark discoloration of the right forearm, oedema of the limb, tense blisters, and the dermatologist diagnosed skin necrosis secondary to amiodarone extravasation. Here we have a perfect case of that could have been you on that interfacility administering it, and how cautious do we need to be? Well, this case was discussed. Plastic surgeons who decided to not proceed with skin grafting because of his acute MI, and the pharmacy advised hot or cold packs and topical steroid cream. Not so comforting to the patient. This is what happened. This is the toxic effects of amiodarone infusion. And that wonderful pH of 3.5 to 4.5. Be mindful of your IV site. Be mindful of how it looks, how it feels. Ask the patient about it. Take care. Amiodarone can be, and we do administer it via peripheral IV, but you have to be very mindful. You have to know, how sure are you of your IV? So wrapping it up, for PICC lines, you disinfect the hub, vigorously scrubbing while counting to 15 Mississippi. Then you grab your second alcohol prep, vigorously scrubbing that port, counting to 15 Mississippi. Let it dry. Draw off your 5 mLs of blood that will probably be heparinized blood. Discard it, flush it, and then you're able to administer your medication or deliver your fluid challenges. But you have to be mindful. It's so easy to cause infection and give the patient sepsis, and you have to know what you're doing and what medication you're administering, and knowing just how harsh it is to the body. This concludes the training on PICC line, and have a great night.